Cervical vertigo. Where's the source? Cervical vertigo is a term that was coined back in 1955 by Ryan and Cope, based on the observation that individuals with cervical spondylosis and those individuals involved in whiplash injury present with a dizziness complaint that did not match the typical vestibular-based causes, such as Meniere's, benign paroxysmal positioning vertigo, or vestibular neuritis. However, there has been little literature support for this concept until fairly recently. The primary question is, where is the dizziness generator, and what is the mechanism of this phenomenon? A recent article attempts to determine if there are histologic indicators of a difference in patients with demonstrable cervical spondylosis versus controls, and whether this may increase risk for developing dizziness, specifically cervicogenic vertigo. The title is Mechanoreceptors in Diseased Cervical Intervertebral Disc and Vertigo, published in Spine in 2017. But before we get to this article, let's review the relevance to chiropractors as it pertains to their patient population. So how often do we see patients with a complaint of dizziness? According to the NBC 2010 Practice Analysis Survey, chiropractors report that they see approximately 1 to 3 patients per month who complain of dizziness. We also know that the overall prevalence of dizziness and balance problems is 5 to 10% in younger adults, but it is also reported that more than 30% of older adults have the complaint. And given a common presentation in chiropractors' offices is patients following acceleration-deceleration injuries, it's important to know that dizziness is one of the top 3 complaints, with up to 70% of chronic whiplash sufferers complaining of dizziness and unsteadiness. Another consideration is the increasing prevalence seen in seniors. For dizziness in seniors, the distribution of cause or dizziness at a dizziness and balance clinic for patients over age 65 breaks out to 32% due to benign paroxysmal positioning vertigo, 22% due to either fear of falling or disuse equilibrium, and 13% due to vestibular loss. All other causes accounted each for 5% or less of cases. Before we proceed to the article, let's review how our central nervous system makes sense of input for balance. Basically, there are 3 main components, which include vestibular, proprioceptive cerebellar, and visual input, and of course the vascular supply for these structures. The primary focus is of course vestibular and proprioceptive cerebellar, given vision is not required for balance. Even from the time of presentation, often these sources of dizziness can be distinguished historically by clarifying a patient's complaint of dizziness. If they complain of room spinning or self-spinning, we typically categorize this as vertigo and know that it is likely vestibular in origin. If dizziness is described as imbalance felt only with standing or walking, the complaint then is termed disequilibrium, and we know that proprioceptive or cerebellar dysfunction is the cause. And with a complaint of lightheadedness or near fainting, we can categorize this as pre-syncope, and we know that this is likely a vascular cause. Starting with vertigo, there is often a cluster of signs and symptoms. By asking questions, 60 to 75% of vertigo patients can be diagnosed, in particular when they have benign paroxysmal positioning vertigo, the most common complaint of spinning. These include true vertigo, length of episodes, and whether there is hearing loss or not, and specific additional questions for BPPV, including positional provocation, such as rotating the head to the right or the left. Spinning dizziness is more commonly due to 3 disorders distinguished by the length of duration of the attacks. BPPV involves recurrent attacks of brief vertigo lasting seconds to minutes with no hearing loss, diagnosed with the Dix-Hallpike maneuver. Meniere's is characterized by recurrent attacks of vertigo lasting hours to days with low-tone tinnitus and hearing loss. And vestibular neuritis, which is severe for days and resolves gradually over several weeks with no hearing loss, often follows an upper respiratory viral infection. For vascular causes, the main focus is orthostatic hypotension, where there is a blunting of the normal sympathetic reflex that causes vasoconstriction of splanchnic veins upon standing, maintaining blood pressure. This is generally due to 2 causes. One is from diabetes due to the decrease of speed of neural transmission, and from blocking sympathetic activity with medications such as antihypertensives. For proprioceptive loss, there are generally three possible causes, two related to the spine. But first, the most common cause in general is diabetes, which leads to both slowing of neural transmission, but also damage to distal nerve endings. And spinal causes, including, as mentioned earlier, whiplash and other neck injury, leading to possible damage of proprioceptors, and myelopathy due to central canal stenosis, often seen in seniors with interference of projection to the central nervous system through the dorsal columns. And of course, the test for proprioceptive loss, regardless of cause, is Romberg's test. The primary role of mechanoreceptors in normal cervical intervertebral discs is to continuously monitor the position, velocity, and acceleration of the cervical spine. Damage may lead to aberrant input, which combines with normal vestibular input. Degenerative cervical discs may have a significant increase in inflammatory mediators and cytokines that hypothetically make mechanoreceptors more sensitive to mechanical stimuli. Also, increase in mechanoreceptor numbers and ingrowth into deep structures, such as the annular fibers or nucleus pulposus, has been proposed. The combination, then, of damage and increase in the number of mechanoreceptors, coupled with inflammation, may lead to changes in muscle tone and muscle spindle setting, all being conveyed to the central nervous system for integration. So the prominent hypotheses of why the cervical spine may be a source of vertigo is that the convergence of aberrant mechanoreceptor information with correct vestibular information may produce a sensory mismatch and thereby result in, quote, vertigo. This is more often described as being off balance versus the typical spinning complaint associated with true vertigo. As mentioned earlier, myelopathy due to canal stenosis in seniors must be considered with the complaint of being off balance or unsteadiness. Myelopathy is uncommon as an undiagnosed problem in our practices, with the exception of that due to canal stenosis. It represents an upper motor neuron lesion and so therefore requires discrimination on neurological evaluation. Testing for myelopathy using an upper motor neuron lesion evaluation includes detection of gait abnormalities, pathological reflexes, and hyperactive deep tendon reflexes, all specific but not sensitive. The inverted supinator sign is probably the most sensitive test. Also, in addition to myelopathy, is spondylosis causing nerve root compression. A study by Karlburg et al. Demonstrated that patients with cervical nerve root compression demonstrated significantly impaired postural control using posturography. Another study showed that vertigo and subjective balance disturbances are common complaints in patients with cervical nerve root compression, and the most common cause of cervical nerve root compression is spondylosis, leading to foraminal encroachment. So who were the patients and controls? Participants included 116 patients who were diagnosed with cervical spondylitic radiculopathy, myelopathy, or both, scheduled for anterior cervical decompression and fusion surgery, who were ages 30 to 69, and 54 complained of vertigo. Patients with vertigo were examined and excluded if determined to have dizziness from neurologic, ophthalmologic, and EENT disease. For the control discs, 40 samples were taken from 8 cadaveric donors within 8 hours of recorded death in hospitals. They were ages 36 to 62. Control samples were selected only if there was no evidence of cervical spondylosis or vertigo in their lifetime and if histology was normal. The researchers then divided cervical disc samples into 3 groups: cervical spondylosis with vertigo, cervical spondylosis without vertigo, and a normal control group. The distribution of age and sex was similar in the 3 groups. So in the present study, the most frequently found mechanoreceptors were Ruffini corpuscles. They only found 3 Golgi endings in these samples in patients with vertigo. There were no Paxinian corpuscles found in any samples of cervical discs. Free nerve fibers were often found in the 3 groups, and their distribution was similar to that of the Ruffini corpuscles. Let's review the histologic findings. First in the control, then the discs of patients with spondylosis and vertigo, and then compare to the discs of patients with spondylosis but without vertigo. Here we see the control group and the Ruffini corpuscles and free nerve fibers found in the anterior longitudinal ligament, the annular fibers, and the nucleus pulposus. We see that Ruffini corpuscles are found in 40% of the AL and free nerve fibers in 55%. In the annular fibers, 20% Ruffini corpuscles and 30% free nerve fibers. In the patients with spondylosis and vertigo, we see that in the AL, we have 74% Ruffini corpuscles and 75% free nerve fibers, quite an increase. In the annular fibers, we see 77% Ruffini corpuscles and 83% free nerve endings, and now we see in the nucleus pulposus 8% Ruffini corpuscles and 12% free nerve fibers. Now, in patients with cervical spondylosis without vertigo, we see in the ALL 53% had Ruffini corpuscles and 72% had free nerve fibers. In the annular fibers, we see 54% with Ruffini corpuscles and 65% free nerve fibers. In the nucleus pulposus, no Ruffini corpuscles and 5% free nerve fibers. So let's summarize the findings. There was an increase in the number and ingrowth of Ruffini corpuscles in the diseased cervical intervertebral discs, especially in the discs from the patients with vertigo. The researchers conclude that there is an association between the increased number and ingrowth of Ruffini corpuscles in diseased cervical discs and the incidence of vertigo in the patients with cervical spondylosis. So the obvious question for chiropractors is there any evidence that manipulation is helpful for cervicogenic dizziness? Well, let's review some of those studies to date. In 2005, there was a systematic review published in Manual Therapy. Here it is, Manual Therapy Treatment of Cervicogenic Dizziness, a systematic review. Based on the review, there were very few studies evaluating cervicogenic dizziness and manual therapy, and most were graded as low-quality evidence. Yet the researchers concluded that they all pointed in the direction of showing benefit from manual therapy and, of course, suggested more higher-quality research. Probably one of the most well-executed studies is Comparison of Outcomes in Neck Pain Patients with and Without Dizziness Undergoing Chiropractic Treatment, a prospective cohort study with 6-month follow-up. This was published in Chiropractic and Manual Therapies in 2013. The results were that the majority of patients with and without dizziness reported clinically relevant improvement at 1, 3, and 6 months, with 80% of patients with dizziness and 78% of patients without dizziness being improved at 6 months. And finally, published in 2015, is a study of survey responses regarding the role of chiropractic care in the treatment of dizziness or balance disorders. This was an analysis of National Health Interview Survey data. The results were interesting. For those who saw a general practitioner, the odds ratio for reporting having been helped by a medical physician was the lowest at 0.95. For those having seen a chiropractor, the odds ratio of perceiving being helped was the highest at 1.73. For the 35% of respondents who were aged 65 years and older, the odds ratio for perceiving being helped by a chiropractor was 4.36, compared with an odds ratio of only 1.13 for those younger than age 65. For patients reporting trauma as their cause, the odds ratio for perceiving that they had been helped by a chiropractor was 9.5, compared to the odds ratio of 0.53 for medical physicians. For participants reporting a neurologic or muscular cause, the odds ratio for being helped by a chiropractor was 13.78. So regardless of the fact we don't know exactly why patients respond, it does appear that there is evidence that for patients who either feel that their dizziness is due to trauma or a neurologic cause, there is improvement superior to that of MD care based on survey response, and that older patients do even better. Is the reason older patients do better because the cause is cervicogenic? We don't yet know the answer to that question, but the study we have reviewed suggests a connection. Further studies, as always, are needed.